What's up, Tumnad lectures? In this video, we're going to be looking on what we call extrinsic cardiac conduction. If you find this video helpful at the end of it, please make sure you like the video, comment down in the comment section, and please subscribe. Let's go ahead and get started. So now, in this video, we are focusing on what we call extrinsic cardiac conduction. But in the previous video, we looked on what we call intrinsic cardiac conduction. We were able to see how this nodal cell was spontaneously depolarizing on its own, and was generating those kind of reaction potentials. And even also, we're also able to see how the depolarization of this nodal cell was leading to the depolarization of the contractile cell and eventually leading to what we call the contraction. On its own, we never had anything like external effect on that process, okay? And we said that the SN node has that intrinsic ability to spontaneously depolarize, sending those action potentials that can depolarize the entire myocardium, leading to the contraction approximately 60 to 100 beats per minute on its own, which we said the automaticity. But now in this video, we want to see how can we increase the normal sinus rhythm above 100 beats per minute, or even also below 100 beats per minute. How do we do that? And that one is going to be involving the effect of what we call the nervous system. Primarily, they're going to be involving what we call the autonomic nervous system, which is going to be mainly focusing on what we call the sympathetic effect and then the parasympathetic effect, okay? Because sometimes during vigorous exercise, the cellular demand for oxygen and nutrients are going to be increasing. For that reason, we also need to increase the heart rate such that we meet the cellular needs of the tissue. So now, how do we do that? Let's go ahead and get started, okay? So now, whenever sympathetic nervous system is activated, you're going to be seeing a release of different kind of the chemicals. You're going to be seeing a release of what we call norepinephrine and even also what we call epinephrine. So now you're going to be having, for example, this kind of the sympathetic nerve. Okay, this kind of the sympathetic nerve. Okay, and this sympathetic nerve is going to be releasing this kind of the chemicals. It's going to be releasing what we call norepinephrine, and even also shall have what we call the release of what we call epinephrine from what we call the adrenal medulla of what we call the adrenal gland. So we shall also have the release of what we call epinephrine. Now, what happens is that when this norepinephrine and epinephrine comes over on this kind of this receptor here, this receptor is a 7-pass transmembrane receptor. Super very important. And this receptor is what we call the beta-1 adrenergic receptor. Okay, this receptor here is what we call a beta-1 adrenergic receptor. And this receptor is going to be a G protein coupled receptor. What do I mean by this? It is going to be having a protein which you call a G protein. And this protein specifically here is going to be a G stimulatory protein, because we have G stimulatory protein, we have what you call G inhibitory protein, we also have what you call the GQ protein. There are very many proteins, but depending on the type of the cell. But for right now, for the case of the beta-1 adrenergic receptor, it is going to be a G protein coupled receptor, and this kind of a G protein is going to be a G stimulatory protein. Okay, is going to be what we call a G stimulatory protein. So now, this is going to be now serving as my G stimulatory protein. And this G stimulatory protein is going to be having subunits. It's going to be having 3 subunits. What are the 3 subunits? You see these subunits here, they are divided into 3. So now, this one here is going to be, for example, our alpha subunit. It's going to be the beta subunit, and this is going to be maybe the gamma subunit. Those are the 3 subunits that are going to be making us our G stimulatory protein. Now, what happens when this norepinephrine and epinephrine binds on this receptor, you're calling it the beta-1 adrenergic receptor, it is going to be now activating this kind of the G stimulatory protein. But this G stimulatory protein, in its inactive form, it is bound to what we call to the GDP. But whenever it becomes activated, it gets rid off of what we call the GDP, and then it binds what we call the GTP. Okay, meaning that whenever it is bound to what we call the GTP, that's when it now becomes fully activated. So now we have now our G stimulatory protein now fully activated, and once it becomes activated, this G stimulatory protein undergoes what we call a conformational process. What do I mean by this? Now, these kind of the subunits are going to be now separating. We're going to be having now the alpha separating from what we call from the beta and then the gamma. But in most cases, the beta and then the gamma, however much is going to be a conformation process, they are always trying to move towards one another. Okay? But the alpha subunits, it separates independent of them. Now, it means that now this is going to be now a G-stimulatory protein alpha, G-stimulatory protein gamma, G-stimulatory protein beta. Now, what's going to be happening now, this activated G protein will go over on this membrane here of this cell and activate this kind of a beautiful kind of this enzyme. You see this enzyme which is going to be on this membrane? This enzyme here is what we call adenyl cyclase. Okay? This enzyme here is what we call the adenyl cyclase. What happens is that this kind of the alpha G-stimulatory protein will come over and then stimulate this kind of the enzyme, and this enzyme turns on. Okay, and once this enzyme turns on, which you are calling the adenyl cyclase, you know what it does? This enzyme is going to be converting ATP into what we call cyclic AMP. That's its major role. Okay, it's going to be converting what we call ATP, going to be converting what we call ATP into what we call cyclic AMP. Okay, now it means you're now going to be having an increase in the levels of what we call cyclic AMP. Now, what happens is that we have a specific type of the beautiful kind of the enzyme that is dependent on the levels of the cyclic AMP. And this enzyme is called cyclic AMP dependent protein kinase enzyme. So now, you see this enzyme? This enzyme is going to be dependent on the levels of what we call cyclic AMP. What happens is that cyclic AMP will come over and stimulate this enzyme, which you are calling protein kinase A. Okay, meaning that for this enzyme to be activated, it needs high levels of what we call cyclic AMP. Okay, and now that this enzyme is activated, which we are calling cyclic AMP, you know what's going to be? This enzyme, it does a lot of the different kind of physiological processes. One of them, for the case of this process, is going to be what we call a phosphorylation process. It is going to be adding phosphor different kind of the protein channels, which are making us different kind of the receptors on this cell. You know how these channels are called? If you remember very well, during the depolarization process, we had these kind of the channels which we called the L-type calcium channels. Now, what happens that this protein kinase A is going to start now phosphorylating these channels. What do I mean when I talk of phosphorylation? It's going to be coming over and it adds what we call the phosphate group. Okay, phosphate group. Now, this process of what we call addition of what we call this phosphate group on these protein channels is what we call phosphorylation. So now when I say protein kinase A is phosphorylating these channels, I'm trying to mean that it is going to be adding those phosphate groups. Now, what is the significance of this? These phosphate groups are like molecular switches. Okay, they're like molecular switches. They are now going to be now slightly widening this channel such that you're going to be having an extensive entry of what we call calcium. Okay, meaning that the calcium which was coming in during the normal sinus region, because of now phosphorylation, you're going to be having a lot of the calcium ions. So you're piling a lot of the calcium ions by the influence of what we call phosphorylation by what we call the protein kinase A. Now, what does that one mean? It means that now the intracellular environment of this cell is going to be becoming electropositive a bit faster. Okay, and if it becomes electropositive a bit faster, it means that we're going to be generating action potentials a bit faster than usual. Okay, and if you generate a lot of the action potentials a bit faster, it means you're going to be making the contractility of the heart even to beat a bit faster. And when we make the contraction of the heart a bit faster, it means we are going to be having an increase in what we call the heart rate. Okay, and if we increase the heart rate beyond 100 beats per minute, that is what we call tachycardia. Okay, so if we increase the heart rate beyond 100 beats per minute, this is what we term as tachycardia. Okay, it is also such another beautiful thing. So now that's how sympathetic effect is going to be increasing what we call the heart rate beyond the normal sinus rhythm. Okay. So now that's briefly the effect of what we call sympathetic nervous system on what we call the nodal cell. Now let's go ahead and see the sympathetic effect on what we call the contractile cell, because it also significantly affects what we call the contractile cell. How does it happen? Whenever sympathetic nervous system is activated, the sympathetic neurons are going to be releasing chemicals like norepinephrine. So now this one here is going to be now my neuron. Okay, it's going to be now my neuron, and this neuron is going to be releasing chemicals like norepinephrine. And of course, at the back of your mind, I want you to know that even also the adrenal medulla from the adrenal gland is releasing chemicals like, for example, epinephrine. Okay. Now, when this norepinephrine and epinephrine binds on this receptor, how do we call this receptor? This receptor here is what we call the beta 1 adrenergic receptor. Okay, this receptor here is what we call the beta 1 adrenergic receptor. Now, when this norepinephrine and epinephrine binds on this receptor is also a G protein coupled receptor. What do I mean by this? It's going to be having an intracellular protein which we call the G stimulatory protein. So now this one here is going to be our G stimulatory protein. If you remember very well, we said that this G stimulatory protein is going to be made up of 3 subunits. It's going to be made up of what we call the G alpha stimulatory protein, what we call the gamma, and then also what we call the beta subunits. Now what happens is that this kind of the G stimulatory protein, in its inactive form, it is bound to what we call the GDP. But whenever norepinephrine and epinephrine binds on this receptor and it activates it gets rid off of what we call the GDP, and then it binds what we call the GTP. Now, this kind of the symmetric protein is now super activated. Now, what happens is that when it becomes activated, it undergoes what we call a conformation process, whereby the G stimulatory alpha is going to be now splitting off from what we call the gamma, and what we call the beta subunits. What happens is that now the activated kind of the G stimulatory alpha subunit will go over on this membrane and activate this beautiful kind of this enzyme. You know how this enzyme is called? This enzyme here is what we call adenyl cyclase. What happens is that this G stimulatory alpha subunit will come over and stimulate this enzyme and turns it on. Once this enzyme is turned on, what is it going to do? This enzyme is going to be converting ATP into what we call cyclic AMP. Okay, it's going to be converting what we call ATP into what we call cyclic AMP. What is the significance of this? We have a specific type of the enzyme that is dependent on the levels of the cyclic AMP, and this enzyme is what we call cyclic AMP dependent protein kinase. Okay, and another name for that enzyme is what we call the protein kinase A. So now, by the increase of the cyclic AMP, this one is going to come over and stimulate this enzyme to become active. And we said that this enzyme is what we call protein kinase A. Okay, once this enzyme protein kinase A becomes activated, there are two things this enzyme is going to be doing. The first one is going to be what we call, you remember this structure here which you call the sarcoplasmic reticulum. Okay, it was a house of what we call calcium. But during contraction, we were having a lot of what we call calcium, which was in what we call the cytoplasm. Now, what happens is that this enzyme called protein kinase A is going to come over on this kind of the sarcoplasmic reticulum. There is a specific kind of the channel which is going to be having a regulator protein, which we call phospholambin. It means that for this channel to work, this phospholambin has to be activated. How is it activated? This protein kinase A will come over and then phosphorylate this kind of the protein which you're calling phospholambin. And once that one happens, this kind of the channel will open and suck all these kind of the calcium ions in this cytoplasm, and then it enters inside what we call the sarcoplasmic reticulum. So now we are piling a lot of the calcium into the sarcoplasm until it is almost going to be bursting, or of course it will not burst. Okay. So now, by the whole point is that the activation of the phosphorylation of what we call phospholamban is increasing the sucking in of calcium back into what we call the sarcoplasmic reticulum. That is one reason of what we call activated protein kinase A in this contractile cell. Another significance of this protein kinase A that it will come over on this kind of these channels which you called voltage gated calcium channels, if you remember very well. These channels, by the influence of what we call protein kinase A, this enzyme will come over and phosphorylate these channels and as what's called the phosphate group. And we said that the significance of what we call phosphorylation is going to be acting as what we call molecular switches. It is going to be now widening this kind of distance such that it's going to be having a massive entry of what we call calcium. Now, by the fact that now these channels are fully phosphorylated, we are going to be now having an extensive entry of what we call calcium. Super at a very high speed. Okay? So now, if you have an extensive entry of what we call calcium, if you remember very well, calcium was inducing release of calcium. It was a beautiful thing. How that is going to happen? If you come on what you call sarcoplasmic reticulum, we had a receptor which we call the ryanodine type 2 receptor. This receptor, whenever calcium comes over and binds on this receptor, it was leading to the opening of this channel. What happens that when calcium comes over and binds on this receptor, what you're calling the ryanodine type 2 receptor, it's now going to be having massive relief of what you call calcium. Okay? So you're going to be now having again an extensive amount of the calcium than the normal. When you have an extensive amount of the calcium than normal in this contractile cell, guess what's going to be happening? Calcium will come over and bind on this kind of the protein which we call troponin. Specifically, it's going to be binding on what we call troponin C. What happens is that when calcium binds on what we call troponin C, it is going to be leading into the pulling away of what we call tropomyosin, because it has been closing the myosin binding site. By the influence of calcium binding on troponin, tropomyosin is going to be now dislodged away, and it exposes what we call the myosin head binding sites. When that one happens, that means you're going to be having now a direct connection between actin and what we call a myosin. And when you have that, it means you're going to be having an extensive amount of what we call post bridges. And following post stroke, we're going to be having an extensive force of contraction being generated. Now, whenever you have an extensive force of contraction, it means it's also going to be increasing on what you call the amount of the blood which is going to be ejected per beat, and which we call the stroke volume. Meaning that this kind of the extensive force of the contraction is going to be increasing what we call stroke volume. Okay, and if you increase stroke volume, you are increasing cardiac output, because we said cardiac output. We said the cardiac output is equal to stroke volume times what we call heart rate. So now, if we have increased the stroke volume, you have increased what we call cardiac output. Okay? So now, that is how sympathetic nervous system is going to be affecting the non-contractile cell and then the contractile cell in the simplest way possible. Okay? Now that we have seen the effect of what we call sympathetic nervous system, which is a flight or fight system, let's go ahead and see now what we call the parasympathetic nervous system. Now, we pretend that we are now seated, we are chilling, we have no problem, everything is sorted. Parasympathetic nervous system is now going to be taking over. So now I want to see how the parasympathetic nervous system is going to be now affecting this kind of the nodal cell. At the back of your mind is that the parasympathetic nervous system is going to be significantly affecting what we call the nodal cell, but it doesn't affect all that significant on what we call the contractile cell. There is not any kind of significant amount of the effect on what we call the contractile cell. For that reason, you're going to be now mainly focusing on what we call the parasympathetic effect on what we call the nodal cell. How is it going to be slowing down what we call the heart rate, even below the normal sinus rhythm, which we call the bradycardia? How does this one happen? When you come over, you have this kind of this receptor here, which is super very important. This receptor here is what we call mascarin type 2 receptor. What happens that whenever parasympathetic nervous system through a cranial nerve which carries the bigger percentage of what you call parasympathetic outflow, which you call the vagus nerve. Vagus nerve is going to be releasing a molecule called acetylcholine. Okay, so now this is going to be now my neuron, and it's going to be now coming over here, and then it releases a beautiful molecule which we call the acetylcholine. Now, when acetylcholine comes over on this receptor, which we are calling the M2 receptor, this receptor is also having a G protein, meaning that this receptor is also a G protein coupled receptor. The fact that this receptor is a G protein coupled receptor, it is going to be containing a specific type of the G protein, which we call the G inhibitory protein. You see this kind of this G protein here, this one here is going to be what you call a G inhibitory protein. Okay, this is how it is different from what you call the beta 1 adrenergic receptor. This one is now a G inhibitory protein, but it also has 3 subunits. It has what you call the alpha, it has what you call the beta, and what you call the gamma. Now, in its inactive form, it is bound to what we call the GDP, but whenever it becomes activated, it gets rid of what you call the GDP, and then it binds what we call the GTP. And now our G inhibitory protein is super activated. Now, once this G inhibitory protein is activated, it is now going to go into what we call conformational changes. And when I talk of that, it means that this kind of the subunits are going to be now splitting, okay, are going to be splitting, meaning that you're going to be having now independent alpha subunit, inhibitory subunit. We shall also have independent gamma and what we call the beta subunits. Now, what's going to be happening after this kind of the separation? This kind of the G inhibitory alpha subunit, it is now going to be coming over, and then it inhibits this enzyme which we are calling adenyl cyclase. Now, once the G inhibitory alpha subunit inhibits an enzyme called adenyl cyclase, it means we are no longer going to be having what we call conversion of ATP into what we call cyclic AMP. It means that you're going to be having now a decrease in what we call the levels of what we call cyclic AMP. If you have a decrease in levels of cyclic AMP, we said that we have an enzyme which is super dependent on what we call levels of what we call cyclic AMP. This enzyme, we called it protein kinase A, meaning that if you have low levels of cyclic AMP, this kind of the protein kinase A is going to become inactive. And once it becomes inactive, we are not going to be having now the phosphorylation of this kind of L-type calcium channels. It means we are going to be now decreasing what we call the level of what we call depolarization. Now, if you reduce the depolarization ability, you're going to be reducing on what we call the generation of what we call the action potentials. If you reduce the generation of action potential, it means you're also going to be reducing the speed of what we call the contractility, which is what we call the heart rate. Okay, it means you're going to be reducing on what we call the heart rate. Now, if you reduce the heart rate to below 60 beats per minute, okay, if you reduce it below 60 beats per minute, this one also is what we call bradycardia. Okay, is what we call bradycardia. So now that is how the G inhibitory alpha subunit is going to be leading to what we call a reduction of what we call heart rate. Now, we also have what we call the beta and what we call the gamma inhibitory subunits. They also exert something which is super very important. You know these channels here? These channels here are what we call the potassium channels. Okay, these channels here are what we call the potassium channels. They are the same as these channels here. These channels here, they are always pushing out what we call potassium ions outside of the cell. What happens that the beta and then the gamma G inhibitory subunits are going to come over and then stimulate these channels even to work the more. Okay, when they work faster than the normal, it means that we're going to be having an extensive amount of the potassium ions that are going to be leaking out. Okay, and even also they also come over here and increase what we call efflux of what we call the potassium ions. Okay, so now if it increases the efflux of what we call potassium, we know that whenever potassium is leaving the cell, this cell is becoming more and more electronegative. And of course, if it's becoming more and more electronegative, it means we are now decreasing on what we call the depolarization ability. If we decrease the depolarization ability, we are decreasing the generation of what we call the action potential. If we decrease the generation of what we call action potential, we are going to be decreasing on what we call the speed of the contraction. And if you reduce the speed of the contraction, of course, you're going to be decreasing what we call heart rate. And if you decrease heart rate below 60 beats per minute, that is what we call brady. That's what we call bradycardia. So now, that is how the G inhibitory subunits are going to be exerting this kind of the inhibitory effect to make sure that the heart rate comes down back into the normal or even below what we call the normal sinus rhythm. Okay? To finish it all, whenever this kind of the sympathetic effect increases what we call on the heart rate, we say sympathetic nervous system is going to be positive chronotropic effect. Okay, so now that briefly covers what we call extrinsic cardiac conduction. Tumnad, I have talked a lot of things, and if you think whatever I have talked is really making sense, is adding to you, you're benefiting, please, you can hit the like button, comment down in the comment section, and please subscribe. As always, Tumnad, until we meet next time.